Okay, we're recording again. Cool. So this is I'll share my screen. Um, this is what it's going to look like from a patient point of view. So this is a handout that they will get. And we could even have this printed on the walls in the clinic. Uh, three key sort of progressions or three stages of exercise rehab that I feel that we go through. I have condensed this down. I did originally have 5 phases, but just to make it simpler for everyone, and patients as well, we've condensed it into 3. So the first phase is the protect and restore phase. So that is where someone comes in for an acute injury, or they have an acute flare up on top of a chronic injury, such as your plantar fascia that's really, really painful at the moment. They will fall into the protect and restore phase of rehab, where the primary goal is to create an environment that allows the injury to recover and pain to reduce to an acceptable level. So this is really just restoring range of movement, getting them walking normally, and making sure they continue with their general fitness as much as they can around the injury, and really just that settling down, deloading. Acute ankle. We're talking here. The first sort of week, maybe even less, depending on the severity of the injury. But we want to, just get things back to normal. And then the second phase is building capacity. So we want to elevate strength to pre-injury levels. So develop the physical capacity of the injured tissue and surrounding structures to pre-injury levels. So here we're working on really reducing asymmetries in mobility and strength, and introducing a little bit of running and plyometric stuff as well towards the back end of that stage. And then the final stage is the return to sport phase. So when they enter the return to sport phase, they're not actually back at sport, but that's what they're working towards. So there we're looking at continuing to build running volume and intensity, and returning back to training and play. And continuing to build maximal and reactive strength as well. So can everyone see or have any ideas as to how this will benefit patients actually giving this to them as a printout? Any thoughts on that?
I think it'll enhance buy-in to the length of actual rehab. I think people that are not really with their own bodily awareness, I think they think an injury will get better within a couple of sessions, whether that be 3 or 4, and don't actually understand that significant change would happen after an actual long period of time, relatively long period of time.
Yep, 100%. I think where this really helps is with that we always talk about criteria-based rehab rather than time-based rehab. So not just saying your ankle's a 3-week injury, your ankle is a however long it takes injury to get you ready to go. That's the whole premise of it. Tess, what do you think of that?
Yeah, no, I think it's really good how it's really clear and directed. I'd be interested to know how we sort of alter it and adapt it to someone like who's not returning to sport, but just like returning to like their, going on, hiking, or going to going on holidays or something like that. That's not going to involve like such sort of intricate dynamic stuff, I suppose.
Mm-hmm. Yep. So return to sport. So their sport can be walking the dog for 30 minutes around the block. That can be their sport. And you just explain that to them. So you can frame this in the way that this is how elite athletes do it. And we're going to treat you like an elite athlete, with your sport being walking the dog. Do you think that would work, Tess?
Yeah, I think it would for most people. Yeah.
And again, going back to that, this is highly adaptable and fluid, and it's not a rigid protocol. It's more going to be a framework that we work around. So And on that as well, like a lot of people will come to see us and they will enter straight into the build capacity phase. They won't be in the protect and restore phase. And the length of time that someone spends in phase 1, phase 2, phase 3 is going to be vastly different depending on the individual, their injury, the severity of the injury. So someone might come to us and, like, if they've got a broken ankle, like if they've got a fracture, they're going to be in protection and restore for 6 weeks minimum. So whereas someone comes in and they've just done a big run on the weekend and their plantar fascia is really grumbly, it might be 1 to 2 weeks to settle that down. Then they move straight into the build capacity. Does that sort of help in understanding that it's not rigid? It's going to be adaptable.
Yep, that's good.
Yeah.
I think maybe just adding on to Tessa's point, I think with our demographic and patient load that we see, it would probably, this model would probably apply to a lot of our cases, maybe sort of 80 to 90%. But then you've got that small group that are probably, maybe lower health literacy, or their goals aren't necessarily a sport. So you can link it maybe to their objective or their goals. So whether their goal is walking around the block, or if it's just, reducing their first step pain or reducing their morning pain, we can make it a little bit more specific to their needs if they're not a sporty person. In that regard, if we're worried about, the patient being like, oh my gosh, am I in the right clinic? Is this all about sporting injuries? That type of mindset. We want to be really approachable in the fact that, no, we're here to cater for your goals. So whether it be, we could even change the title to return to goal, or something that could be like less, I know this is very sporty rehab, or there could be a way we could maybe relay that information to the patient and just say, look, this is how we can return you to the goal or the objective that you want to have no morning pain, and then get you to your future goal of starting personal training or something like that. You know what I mean?
Yeah, so your suggestion was to change return to sport to something else. And yeah, that's a good point. We can continue to brainstorm that. Although so I want continued feedback on this, and we will, like I said, going to battle test it. Like, it's probably going to take a good 12 months to really get this right. So yeah, we can, there's always room to change wording of things. But I think it's more the implementation that's going to matter more so than the specific wording of things that can come later. But yeah, open to that as well.
I think JT, I think a cool thing of this as well, we'll obviously have a cohort of patients that just don't care in regards to, like, I don't really care about playing the sport, I just want to be better. It's a good tool just so that they're aware of what the actual process of any kind of injury rehab will take. For example, if she's an 80-year-old lady, like, she's not going to care. Just fix me. I don't care. Just fix me. But for that cohort of people who don't care, I think this is also a valuable tool. Just for their own knowledge. I think it's a great tool in general.
Yeah, and also thinking as well about who our ideal patient is, and I really want to see people who are going to go into this model. So yeah, there are going to be people that don't fit this 100%, but I probably don't want to be working with them anyway. So long term. So yeah, so there's still be people who will go and we'll just see them session by session, do what we normally do, just progress them as we see fit with a general goal in mind, and that's fine. But when there are, I'd argue that, a lot of those people will fit this model. We just need to maybe see the opportunity to, present it to them and explain it well, etc. But yeah, I think if we're thinking about being elite in what we do, like, this is what we need to be doing with elite athletes, but it can be with everyday people as well. Eventually it will just become sort of known that this is what we do with everyone. So we'll start to attract more of those patients that want this. So those guys that it doesn't fit are probably, we won't really worry about them at this point. Andrew, would you kind of agree with that, or is there anything to add there?
Well, all I'm thinking is that perhaps with those sorts of patients who returning to a level of activity isn't a huge priority, you'd still be the phase 1 and 2 would still be no different. It's probably just that they may not spend as much time with us in phase 3. So like they're probably going to spend exactly the same amount of time in phase 1 and phase 2, because that's kind of unavoidable if we're dealing with a soft tissue injury, particularly, or anything really. They're going to need to keep the pain down and get the movement back. You're going to obviously have to actually rehab it, because we know that's consistent whether you've done it at work or you've done it on the sporting field. But perhaps that return to sport phase, well, I think our goal should be more so the fact that if we have an athlete, we are doing this, because I would argue, I think that's where we perhaps, I know I do, certainly probably fall down on. So I feel like I can do 1 and 2 okay, but 3 is probably not. We are consistently doing it. So for those people that need it, I think if we're consistently doing it, for those that perhaps don't need it as much, well, maybe that's not a huge priority. But for those, I feel like more so if we shift it, let's focus less on the 5-10%. Let's focus on the 90%. And if the 90% are trying to get back to some level of activity, and we're perhaps at the moment not doing that consistently, then I think that's certainly an opportunity for us to really level up on and get that really nailed. Because as you said, I think that's something that we can become more known for.
Yep. And the underneath the build capacity phase down the bottom where it says introduce impact and return to run, like that can be introduce walking and return to hiking. Like it can be whatever. Again, highly adaptable. You just have to explain that to the patient. So yeah, this is what it looks like from the patient point of view. This is what they will get, and you'll be able to talk to where they fit into this and the process, and then you can explain like how long it gets to get out of phase 1. Maybe for you, it's going to be about 2 weeks, but only once we've ticked off those key goals there, and we've moved on to the next phase. So what it looks like on our end is going to be in the form of a sheet or Google Doc, or with some, a bit more detail, a bit more nuance. Again, trying to make it as simple as possible for us. But I think if we work through it and study it, it will make a lot of sense. And it's more just for us to refer back to and check what we're doing against this framework. So here are the phases 1, 2, and 3, and the goals that were in the underneath the previous sheet. I've got here where orthoses, shockwave, and soft tissue therapies fit in as well. So that was one of the questions that Andrew put to me, like, not just for exercise rehab, like how does this fit into everything else that we do? Because this is the phase that we're really good at, and we do a lot of shockwave, we do a lot of orthoses. So where does that fit in, and how do we explain to the patient where that fits in as well? So yeah, it's color coded. So green means that it's applicable to that goal. So promoting tissue healing, orthoses do that, shockwave does that, soft tissue therapies don't really do that. Restoring range of movement, orthoses don't do that, shockwave does, soft tissue work does, etc., etc. So orthoses can help someone to conserve their global fitness level because they are able to exercise with less stress through their feet. And you see, as we move from phase 1 to phase 2, these adjunct therapies become less necessary. So they still may come in. For example, orthoses introducing impact and return to run. So when we're in that build capacity phase, we've been going really well so far without orthoses. We're doing all of our strength work. We're building strength. We're building flexibility. But when we actually get them to try to go back into their running, they start to get niggles of pain again, or they just can't cross that hurdle. That's where orthoses could come in again in that phase. So they are still relevant, but less relevant in phase 2. And into phase 3 as well. We shouldn't really be doing, in the return to sport phase, we shouldn't really be doing any hands-on therapies. We would assume that we're past that point now. And orthoses may still come in if we're building running volume, but they can't handle, higher intensity stuff, sprinting, change of direction, they're still getting flare-ups, then perhaps orthoses are still relevant. Any questions on that, like how these adjuncts fit into the 3 phases?
Not so much a question regarding what you're saying, but just out of pure curiosity, what do the Athlete Authority charge for like a 12-month program or membership, whatever it's called?
Yeah, a lot. Great question. I've forgotten actually. It'd be for 12 months, it'd be up there. It'd be like $8,000 or something at least.
Yep.
But yeah, that's probably getting more into the business side of things. So that's like sort of maybe like an end goal of this stuff is we can start to look at things like that. But the first phase for us, I think, will be just to get the actual process and framework like battle tested, and there'll be issues with it that we'll have to change things and find what works. And then once we're pretty confident that it works, then we can look at stuff like that.
There certainly isn't any immediate thought of getting them on a sort of a subscription model. I think there's some benefit to that potentially down the track, but I think in the short term it's more about seeing if we can just nail this and get this working really, really well before we even consider something like that.
But yeah, good question. Keen to keep those discussions open as well. This is the thing for us, and also probably for patients as well, is exit criteria. I realize we've only got 2 minutes left, so we've only got the half an hour, Andrew? Or?
We do, but I think I've allocated the next hour session, so I thought we could sort of understand it a bit and then go into a bit more detail next time.
Yep. So I'll just quickly go through this. The exit criteria. Okay. So this is condition specific, right? So over here, we've got the general goals of each phase. That's across the board for every condition. All right. Whereas exit criteria are condition specific. So for plantar fascia, which is what this one is, to exit phase 1 and for someone to move into phase 2, they need to have ticked off these 4 things. So they need to be walking normally without limping. So they can still have pain, but they just can't be limping. They need to have their normal walking gait back. Their range of movement needs to be within 10%. So that's with your knee to wall, your first 10 TPJ, and your hamstring. You'd want them left and right to be within 10% of each other. Need a wall test pain-free, and windlass tests pain-free. And those 2 things are in your in the P3 module on plantar fascia testing. That's where that fits in as well. So these special tests, we need to be pain-free with those. So if you see someone for the first time and they're pain-free with this stuff and they're walking normally, then they don't go into this phase. They move straight into build capacity. But again, there's going to be some practitioner discretion there as well. You might feel it's still appropriate for them to be in phase 1, but these exit criteria give you some really good guidelines around that. And then I've also got here where our testing fits in. So like looking at all of this, it might be a bit like overwhelming. There's a lot of detail and stuff, but if you study it and look to implement it and refer back to it, I think it should all make sense. Like I think it's all sectioned together really well. So like looking at what handheld dyno testing you would do, force dex testing, well, you wouldn't do any if someone's in the protect and restore phase. Gait analysis, what you would look at, you'd look at their walking gait, whereas down here you might look at someone's running gait a bit more. And what special tests are we doing, and what patient-reported outcome measures could we consider in this phase? So even if you don't do all of this stuff, like there's still at least all the information's here for you as to refer back to, and for everyone to be on the same page of what you could do. But not everyone's going to have to tick every single box and do every single test. So, but yeah, I just want to have it all in one place for us. Does that make sense?
Awesome. Well, we better quickly wrap it up. But I thought, thanks so much, Jackson, for all your work putting this together. I think what I'm really excited about this, and what's my real sort of potential game changer for us, is that it's, as you said at the start, it's perhaps eliminating the guesswork in terms of, like, we think this should be, we should be here at 3 weeks, you should be here at 4 weeks. We're actually doing objective tests to work out where someone realistically is at. So we're giving them a much more, while this is a framework, we're actually being much more specific with our treatment. And I'm super excited about that. And I think the patient can understand that better when they can actually see, I can't walk pain-free, therefore, we can't progress until you can.
Yeah, and a lot of this stuff is evidence-based, and a lot of it is also just my brain that I've put together over the past few years. So, yeah, but keen to test it. We'll roll it out. We'll have another session on it next week, a bit more sort of detail, and then yeah, we'll look to roll it out maybe soon, if not definitely next year. So, cool.
Cool.
Thanks, Jackson.
Thanks, guys.
Thanks, Jackson. Looking good.
Thanks, guys.
You guys.
Yeah.